chemotherapy molecules by definition. Chemotherapy means a drug that treats something. So they're all chemotherapies. So I will add cytotoxic chemotherapy free. These are my... So what am I going to talk about and what am I not going to talk about? Well, I'm going to talk about antibodies directed against tumors. I'm going to talk about immunomodulatory drugs. I'm going to talk about pathway inhibitors. I'm probably going to skip the immunotherapy because we just heard it. What am I not going to talk about? I'm not going to talk about nonspecific cytotoxics. I'm not going to talk about immunochemotherapy. And I'm not going to talk about immunoconjugates because they're basically just water boys to use antibodies to bring real chemotherapy to cells. So some things to remember here, and these are actually important. So as we're going through the talk, keep these in mind. Cytotoxic-free regimens tend to accentuate the difference between the indolent NHLs. So, we're used to, you give R-CHOP, you give, RCVP, you give R-bendamustine. It doesn't matter if it's nodal marginal zone lymphoma or follicular lymphoma. Not so true with these molecules. Pay attention to that. Continuous therapy is difficult on patients because of chronic, albeit low-grade and sometimes not so low-grade toxicities and the financial burden. I'm not going to emphasize the toxicity because I just don't have time to go into a lot of it. But remember, chemotherapy-free is not toxicity-free. And combinations are really what are needed, and we've touched a little bit upon the need for combination therapy. So when we think about the targeting tumors, we have to think about that the tumors live in a microenvironment. So there are different ways we can go about targeting a lymphoma. We can target the tumor cell. Tumor cell has a whole bunch of different surface molecules. We can use molecules directed at those surface molecules, and clearly in B-cell malignancies, the single most effective immunotherapy, targeted therapy that's ever been developed is rituximab. We can use pathway inhibitors, that's another option. And then finally, we can actually try to target the microenvironment itself by altering the effectiveness of the cells within the microenvironment, and this is the mechanism largely by which IMiDs work in indolent lymphoma as well as the checkpoint inhibitors. So what about single-agent rituximab? And this is going to be sort of an overview. This is largely conceptual. So why am I talking about single-agent rituximab? For God's sakes, this is not November of 1997, But I'm going to talk about single-agent rituximab because I want to remind you that all indolent lymphomas are not created equal. So let's look at the RESORT trial. The RESORT trial was a monotherapy rituximab trial, 4 doses of rituximab followed by maintenance rituximab forever versus rituximab at retreatment. In reality, it was actually difficult to give rituximab maintenance forever, and a lot of patients walked away from the study, but walked away from the study after a pretty substantial amount of treatment. If we look at the results, now I've combined the 2 arms of the study. There was a follicular and a non-follicular study. And one of the things that's really important to see here is the single-agent response rate for follicular lymphoma was 71%. For the non-follicular lymphomas, we had splenic marginal zone lymphoma, 100%. We had small lymphocytic lymphoma, 23%. So when we look at non-follicular versus follicular, there was a highly statistically significant difference in the response rate. Remember, you don't even get on to the next part of the study unless you've responded. So most of the patients with follicular lymphoma go on to the next part of the study. Only a minority of patients with non-follicular lymphoma go on to the next part of the study. So people who are responding, PRs or CRs, are then randomized. If we look, the likelihood of being in a CR was actually pretty similar if you had follicular or non-follicular lymphoma. About 15 to 20% of patients were in CR and the rest were PR. If we look at the amount of drug you had to give in these 2 different strategies, so retreatment at relapse, you only got 4.5 to 6 doses of rituximab, a whole lot cheaper than giving maintenance, because maintenance required 16 doses in follicular lymphoma and about 18 doses in the non-follicular lymphoma. So the question is it worth giving 4 times the amount of drug? Is there a benefit? And so here's the integrated analysis that Brad Call showed. And here is these dotted lines are the retreatment follicular versus maintenance follicular, and I would argue that there's absolutely no difference between those curves. This was the primary endpoint of the study. So in follicular lymphoma, where the response rate is very high to single-agent rituximab, retreatment is the superior strategy. Interestingly, if you respond and you're a non-follicular patient, you actually do better by getting persistent maintenance therapy than not. So here's a perfect example where we're seeing a marked difference between a maintenance strategy, not maintenance strategy, depends on what histology you have. I actually use this information clinically. Time to next first cytotoxic chemotherapy, markedly different in the non-follicular group. Okay. So what about immunomodulatory therapy? Lenalidomide is a pleiotropic inhibitor of lymphoid cells. We know how it works now. The IMiDs bind to cereblon. Cereblon is a critical component of the E3 ubiquitin ligase, and it changes the substrate specificity and the metabolism of certain proteins. In IMiDs, particularly lenalidomide, is particularly important for the rapid breakdown of Ikaros and Aiolos, two zinc finger transcription factors that are really critical in lymphoid biology. And what does that do? Well, it will modulate NK activity and dramatically enhance antibody-mediated cell cytotoxicity. It enhances direct killing by NK cells. It dramatically improves killing by T cells by repairing the immune synapse. There are some microenvironment changes. We don't know how important they are in the lymphomas. It's probably the major mechanism of action in myeloma. And there are direct effects on the tumor cell, though probably less important in the indolent lymphomas. So one of the first studies to look at the role of lenalidomide in follicular lymphoma was this CLGB study that we did, and I was a purist. This was one of the first big studies to be done in the rituximab era, and we were going to look at rituximab in one of the arms. I wanted to know what single-agent rituximab did in previously treated rituximab patients, because everyone said, oh, it's 50% drug. Well, maybe not in the relapse setting. So I was the purist, and I insisted that we had this arm, and this study was open, and it was open, and it was open, and we got 12 patients on study. And so we said, okay, we either have to commit or give up. So we decided, let's get rid of the rituximab arm. I wept at the meeting because I was the purist, but the purist was wrong, because we actually then accrued this in about 6 months. So we had 90 patients, about half treated with lenalidomide and half treated with rituximab lenalidomide. And lenalidomide had single-agent activity. It was actually pretty substantial. About half of the patients responded. But impressively, we doubled the complete response rate by adding rituximab, and this makes sense based on the mechanism of action of lenalidomide, because we enhanced ADCC, and this translated to a progression-free survival difference, but waiting for overall survival update. So this led Nathan Fowler to ask the question, well, what happens if we do this up front, adding rituximab and lenalidomide? Patients were treated for 6 months. If they had a good clinical benefit but weren't in a CR, they got another 12 months. One of the things that people really never read very carefully about this paper is the vast majority of patients only got 6 months of therapy. Only a minority got 12 months of therapy. So here it is. Again, this points out the difference between different subtypes. Small lymphocytic lymphoma, a very reasonable 80% response rate, but only 20% CRs. Let's look at follicular lymphoma, 98% overall response rate, and 87, I think is the number, 87% complete responses. And marginal zone lymphoma was in the middle with an 89% response rate and 2/3 were CRs. Here are the curves. Overall survival, all three groups is excellent, while these were untreated patients and it's relatively short follow-up. But we can see the durability is superior for the follicular lymphoma patients in the upper right-hand panel compared to the marginal zone in the lower left and the small lymphocytic in the lower right. This was confirmed in a CLGB Alliance study, which is sort of ironic because we started our study first, but Nathan got his done faster. So ours was the confirmatory study. It's very sad. But we got almost the same results. You might say, well, he got 98% and 87%. Well, this was a multi-center trial, and we have all the issues of multi-center trials, missing bone marrows and the like. But I would actually argue that a 93% overall response rate with a 72% complete response rate is confirmatory of the MD Anderson result. Our trial in the CLGB was restricted to follicular lymphoma, so I don't have the cross comparisons. So this has been tested in the upfront setting with the relevance trial, and this is R-chemo versus R-lenalidomide, and the study is in the can, and we're waiting results. The reason I made a big deal about the 6 months of therapy in the Fowler study, this is 30 months of treatment in both arms. I think we went way overboard in the length of therapy here. Everyone gets induction and maintenance. I'm not sure I love the design, but that's the way it is. What about B-cell pathway inhibitors? PI3 kinase is an important pathway inhibitor, but I want to dispel the notion that these kinase inhibitors are B-cell receptor kinase inhibitors. They are not. Just forget what you read in the ads. These are not B-cell receptor kinase inhibitors. These are pathway inhibitors that happen to inhibit a number of critical pathways in B cells. In fact, in CLL, I would argue the most important pathway is the inhibition of CXCR4 and CXCR5, both for ibrutinib and for idelalisib. But we can see PI3 kinase is downstream of a number of critical signaling molecules in the B cell. Idelalisib was studied in indolent NHL, the so-called double refractory population. These are patients who were either non-responsive or progressed within 6 months of rituximab and non-responsive or progressive within 6 months of an alkylator. The primary endpoint was overall response with PFS as a secondary endpoint. The patient population is shown here. About half of the patients had follicular lymphoma. Again, we have a smattering of other diagnoses. Unfortunately, a tiny population of Waldenstrom's, and the reason I'm already foreshadowing the result, because maybe we want more patients with Waldenstrom's. So here is the waterfall plot. Again, the waterfall plot, despite the overall response rate only being 57%, most of the patients actually had clinical reduction in lymph nodes, and that led to a median progression-free survival of a year, just under a year. If we look at, again, the different subsets, we do see some differences. Follicular lymphoma, the overall response rate was 54%. Higher in small lymphocytic lymphoma, not surprising, this is already approved in CLL. But look at Waldenstrom's, 80% response rate. Well, if that's real, that's fabulous. However, the problem is the confidence intervals are like 20% to 100% because of the tiny numbers here. What about BTK inhibition? We've already heard a lot about BTK inhibition in CLL. And at ASH, we saw the presentation of ibrutinib for marginal zone lymphoma. This was all types of marginal zone lymphoma, splenic, nodal, and extranodal. They had to have relapsed refractory disease. Patients were treated with the mantle cell dose of 560 milligrams oral daily, and overall response was the primary endpoint. Here are the patient characteristics. The median age was 66. And we have a breakdown of the different subtypes of marginal zone lymphoma. The median number of prior treatments was 2, and you can see that some patients only had rituximab monotherapy, but many of the patients had chemoimmunotherapy. Very few patients had prior transplant. Here are the response rates, and the investigator and independent review responses are really quite similar, about 50% overall response rate, and this actually response rate met the criteria pre-specified and actually has enabled a label extension for ibrutinib into marginal zone lymphoma. Here are the time to event curves, and this was a relatively favorable population with only 2 prior treatments, which is why the overall survival looks as good as it does. But the median progression-free survival, particularly in splenic marginal zone lymphoma, looks quite favorable at 19 months. Certainly doesn't look as good in the nodal marginal zone lymphomas. Now, at the same time, we actually looked at the role of ibrutinib in follicular lymphoma, right? They're all the same, CLL, follicular lymphoma, marginal, they're all the same. Just give them ibrutinib, right? Well, not really. Here is the patient population. There were 110 patients on this study. This was just relapse refractory disease, again given at 560 milligrams a day. Waterfall plot doesn't look nearly as good as even the idelalisib, or a whole lot of not very good responses here, and a whole lot of primary progressors. And that actually fits with the overall response rate of a whopping 21%, which did not exclude the futility analysis of 19%. So here are the time to event endpoints. They're unfortunately rather concerning, with a progression-free survival of 4.6 months. However, and this comes back to the need for biomarkers and to try to understand more about the disease. For the patients who actually responded, duration of response was 19 months. Well, so if you win, you really sort of win, but most patients didn't win. Well, how do we know who they are? And that's really one of the big questions. And here are the time to event curves. You can see even with the duration of response, this is not it's not plateauing, so these responses are only so good. Now, I said all indolent lymphomas are not created equal. Well, here's another indolent lymphoma, Waldenstrom's macroglobulinemia, and treated with single agent ibrutinib. The very good PR in 10 patients, of partial response in 36 patients, decreased or resolved adenopathy in 68% of patients, decreased splenomegaly in 57%, and the pre-treatment characteristics corresponded to response, but that's the progression-free and overall survival. This looks a whole lot like CLL, and even different than what we saw with marginal zone, and quite different, obviously, that we saw from follicular lymphoma. So there really are important differences with these targeted agents between the different subtypes. What about targeting apoptosis? I'm not going to go through this because you've heard the introduction. You have to ramp up, that's true. Let's look at some of the indolent lymphomas here. In fact, single agent venetoclax, you would think, was made for follicular lymphoma. Follicular lymphoma, the 14-18 translocation, overexpression of BCL2, we get lots of BCL2, and there's only a 38% response rate. Now, when we first started developing anti-BCL2 drugs more than 10 years ago, I actually had told the company, we'll do the single agent thing. This was Genesense, this was a long time ago. But it's never going to work because you have to induce apoptosis and then add a suppressor of apoptosis, and then you'll get activity. And that might be true, but we now know in CLL and mantle cell, these drugs actually are substantial single agents. Okay, I'm going to skip the checkpoint inhibition because you actually just heard it in a more elegant way. To add one thing, don't do this at home. These combinations you can't make up yourself. You can't say, oh, gee, I'd really like to do ibrutinib plus lenalidomide. I'm going to do this at home. Well, sick idelalisib, phase 1 study, had to be stopped because of severe steroid-responsive pneumonitis in 14% of patients with 2 deaths. Rituximab, lenalidomide, idelalisib in the CLGB actually had to be stopped because of unexpected severe hepatotoxicity. And the rituximab, lenalidomide, ibrutinib that the Nordic group seemed to get away with, we did not get away with in the CLGB with a substantial rash. The dosing, the duration are a little bit different, and I think that actually has a lot to do with the differences, and allopurinol was probably a complicating factor. A lot of these toxicities are on-target and off-target effects, and some of these quote-unquote off-target effects are actually on target because these are pretty broad targeted molecules. So knowing what the toxicities are of these combinations are not known. You can't just put them together any which way. You actually have to be careful. So the future direction is clearly to look at novel combinations in careful ways with novel treatment designs, and we actually have a few of these trying to look at sub-therapeutic individual doses to try to get synergy of combinations. And I invite you all to the Lymphoma Symposium at Memorial on May 5th. And so with that, I would like Jay Park to come up and talk to us because everyone